I'm the organizer of this along with Carly Eastin, who is going under the name Travis this morning. She grabbed her husband's name badge instead. But, and we, so we've reviewed a lot of, we've read a lot of retrospective medical record reviews. I'm sure you all have. And a lot of them get it wrong. And the question is, how can you do it right so that you get it published the first time and don't get rejected so often? And hopefully we'll give you guys the tools to do that today. Let me introduce the rest of our crew here. Andrew Metz, I always get your name wrong.
Meltzer, Andrew Meltzer. Hi, yeah, I'm from GW.
Anyway, Andrew Meltzer, Martin Wegman, raise your hand, Martin. Peter Hu, and Mike Gottlieb. And what we're gonna do is talk to you for about 10 minutes. Martin's gonna give you a little overview of what the hell is going on, why is this a problem, and then we'll break you into small groups and you'll all sit around a table. Oops, I'm sorry, they didn't give us tables. Well, we'll have you like form little pods and we'll go over a paper and talk about what they're missing and what they might have done better or differently. And then we'll get back together again at the end and talk about some good examples of medical record review studies. So without further ado.
Thanks. Thank you all. Thanks for coming this morning. 8 a.m. for chart reviews. It's going to be good. We'll try to keep you all interested. So chart reviews, I think this is an important topic because I think it's something we all do, and I think, at least early in my career, I wasted a lot of people's time by doing it wrong. You get the med students who come in and they say they want to do research. The chart reviews is sort of the obvious thing to do for the summer. It spends a lot of time, and then by the end of it, you're really not sure of what you really got there, and did you do the right methods to sort of make it work and make it something that is usable. Chart reviews now are generally EHR, obviously, not going through paper charts. And hopefully we're getting more and more to an automated type situation with chart review, so it's less of sort of the manual flipping through charts. But there's a lot of ways to make mistakes. There are ways to do it right, and it's really, I think it's pretty easy to do it right and just do sort of your best possible methods, as good as any expert in the country, and that's what's sort of nice about it. To me, it's like, it's hard to be a great chef because it's just so complicated. It's lots of, different techniques and stuff, but it's pretty easy to be like a good cocktail maker. You could to make a great martini, it's 2 ingredients, so easy. So chart reviews are sort of the cocktails of the culinary world. So you can be the best martini maker easily. You can be the best chart review methodologist probably after this hour, I think, as good as anybody in the country, I think. So they can be very time consuming, often the first exposure of research to young people, and it's really an easy way to turn people off to research if you don't do it well. So you want to, I think, do it right. It's about 25% of all of our studies that we put out in EM journals, and the data's already collected, so you can sort of much easier. You don't have to have your research assistants prospectively consenting. Problems is that EHRs are, as we know, are not typically made for research. They're made for billing for the most part, and we have to adapt. This is the granddaddy of the chart review papers. There's 3 big papers we're going to talk about. This is the first one. This is the one that almost everybody cites in their chart review manuscript. And so if you're going to read one paper, I'd read this one. It's 1996. So pretty long ago, but it hasn't changed that much. So this is, I always want to say, it's Gilbert and Lowenstein, or I always think Gilbert and Sullivan, but Gilbert and Lowenstein. And Gilbert and Sullivan, I believe, are musical composers. But this is Gilbert and Lowenstein. So there's 8 things that you need to know. It looks like it's hard to see, but this is the Elite 8, the Gilbert Lowenstein study. So if you can hit these 8 things, at least address them in your paper, at least think about them before. You might not be able to get all of them and make it perfect, but if you don't think about them, someone's going to criticize you, because I guarantee you, your peer reviewers know this study, and they know these 8 things. So the first thing is just training your abstractor. So, I mean, that's generally going to be often your med students, maybe your research staff, sometimes it's junior faculty. So just letting them know, this is how we're going to go through it, having a meeting, talking about it. Having very specific case selection. So this is a big one. you have to have really defined protocols. You can't just say, all right, I'm going to flip through these charts or I'm going to search in this random way. You got to have a real structured way, almost thinking about it as a consort diagram, just like you would with an RCT, where your patients sort of flow from one box to the next box to the next box. Clearly defined variables, very important. Those people in here who have sort of computer science backgrounds, this really helps to have somebody who's really can think really sort of scientifically and discretely about what you're looking for, whether or not it's going to be the first pulse ox or the second pulse ox, whether or not it's going to be the triage vital signs or the first vital signs with the nurse. It can be very confusing once you start getting into the chart about which one you're actually collecting. Abstraction forms. For the most part, these are Excel sheets. These are very specific, very sort of straightforward forms. Often people use REDCap. So it's basically you create your form, but you got to do it beforehand. And I would say you do a few charts, work through it, modify your abstraction forms to make sure that they basically match up with your charts. Got to meet regularly. A big problem is that senior faculty just say, here's the chart review. Med student, junior faculty, resident, just go to it. You don't meet again for like 3 months, and then it's really just a lot of wasted time and sort of crap. You got to meet regularly as a senior investigator and make sure things are sort of moving smoothly. You got to monitor it. This is the number 7 is the part where I think it's really hard to do with learners. The idea is that you're going to blind the people who are doing chart abstraction to what the purpose of the study is. That's pretty hard to bring in like an MS3 or MS4 and say, hey, I got a great study for you, but I'm not going to tell you what it's about. Here's 1,000 charts. Have fun. I'll tell you at the end. That's sort of hard to do, but I mean, as long as you address it and say, okay, our chart abstractors, we tried to blind, we couldn't blind, this is a limitation, they weren't blinded. I mean, I think you usually still get published, but it could be a limitation. The idea being that if the abstractor knows what the purpose of the study is, it's potentially a limitation. They might know the hypothesis, maybe it somehow biases them as they abstract the data. This last one, this is one I think I pretty much always do, is having some inter-rater agreement. I think commonly people use 10%, so that basically means that you have 2 abstractors and then about 10% overlap where both of them do the same charts. And then you look through them and you see if they match up. If you want to be fancy, you do an inter-rater agreement, a kappa score, but basically you just look through them and see where the mistakes are, and maybe you have some policy of resolving those mistakes. Yes?
Single one of these in the paper, or do you just cite the paper and say you use the methodology as outlined?
Yeah, it's a good point. I sometimes do that second part where I just say I've done my methodology according to best practices and then cite this journal. Sometimes I will go through each one. I think it sort of depends on the editor. I've done it both ways. I think if you can give more detail in the methods, if you have space, I do think people like that because sometimes you can sort of just gloss through it. Some people just cite this paper and really don't do these things. So I think the more you can do, the better. Sometimes they do require a checklist also in some of the higher level journals where you have to go through each of these things and they say, did you do it? Yes, no, yes, no, yes, no. So I think it'll depend a little bit on the journal and the editor. But yeah, good question. So this is the second paper. This is the one that added to the Gilbert and Lowenstein. This is the Worcester. This was about 9 years later, 2005. Added 4 more elements. So we had those first 8. Now we have 12 elements. So it starts to get a little more complicated, but it's basically stuff that you already know and do. This was just sort of a way to add a little more detail to what was already out there. So basically the 9, 10, 11, 12 is just describing how you got your medical records, what's the database you used. Typically, again, it's going to be Cerner or Epic for the most part. What was your method? Is this consecutive? You got to say the dates. Is this, random sampling or not? This number 11 is often the most complicated part, and for me, that usually requires a statistician to come up with a missing data plan. And there's a lot of different ways to deal with missing data, and it depends a lot on whether or not this data is randomly missing or if it's missing per group. And there's sort of different techniques to deal with that, and I'm sure there's dedicated lectures to deal with missing data at this conference. And then the final thing, of course, is Irb approval. All of this stuff we're doing is for generalizable knowledge with a plan to publish, which makes it research, which means we want to have an IRB. So if you were just doing this for just your clinical work, not a study, doesn't need IRB. If you're doing it just for quality improvement, not a study, doesn't need IRB. But if you're using it for generalizable knowledge, typically you're going to need an IRB. And in my institution, it's up to the investigator to know and decide for themselves whether or not this is research or not and go to the IRB. They're not the ones that decide for you. The final paper, and then I'll be done and we'll move on, is this one, 2014 Kaji. And this adds a little more detail to it. So it's, again, 3 papers, and you're the biggest expert in the world on chart reviews. This was by Amy Kaji, looking through the retrospectoscope. I think I said that right. Reducing bias in emergency medicine chart review studies. So it just adds a little more detail about common pitfalls you can have with a chart review study. And I think the big thing here is, one, the chart review just wasn't a great study design for your question. So you sort of have to step back, and sometimes the chart review is the only way to answer a question. Sometimes it's really not the best way to do it. I think dealing with the fourth bullet, data conflicts, to me this comes up a lot, and I sort of mentioned this earlier, but when you have pulse ox listed in multiple different places, and you just have to be really clear about where you want your people abstracting that number, because you can get a lot of variability about where they find that number. And then percent check for liability, I mean, again, usually 10% and then missing data. I think the solutions, I think of just thinking about this really structurally as research at the beginning and not just thinking about as a whole bunch of charts on angioedema, let's go through it and figure out what we're gonna find, but thinking about, okay, we have this ICD-10 code, we have this EHR, we're gonna search angioedema, we have these structured elements we're gonna look for, I'm gonna have these 2 abstractors doing it, we're gonna have a 10% overlap, we're gonna get this data, this is how we plan to analyze it, this is what we're gonna do with the missing stuff. So thinking through all that stuff before you do it, thinking about it just like you would with any protocol, thinking about an analysis plan, so you don't spend 3 months all summer, get all this data back, and then feel like, oh man, what a waste of time. Now let's do some chart reviews.
Thanks, Andrew. Let me see, we have, no tables in here, which makes things a little bit awkward. But what we're going to ask you to form is little pods of like 4 people. And so that'll be like 4 or 5 groups, something like that. So why don't you get 4 people together. Kristen, you're going to help us to kind of herd all these cats here. And sorry, that's a term from the 50s. It's not a 4-legged feline. So kind of move the chairs around to, I think we can do that. Yep, we can. Why don't you just swivel around and join these people here. Come on, join us. You're not too late. No, we're forming little groups. One there, one there. There are 2 groups there, so join these guys in the back row here. Kristen, you want to make those 2 groups? And there's 4, and then, yeah, you can join. Okay, good. And we're going to give, each group is going to get, each group's going to get a slightly different paper. 1, 2, 3, 4, and behind you is 5 and 6. So we got 6 groups, perfect. Take one, you and I'll take one of those 2 groups here. Yeah, it'll make it a lot easier if you kind of move your chairs around and form little circles. You guys are way too big a group. Why don't you split in half? 1, 2, 3, 4, 5, 6, 7. Yeah. So make 2 groups so you can really get in. Oh no, wait, you're one of us. So it's only 6 of them. Oh, maybe that's okay.
It's okay?
Yeah. I mean, you're the leftover, because you sat on this side of the room. That's what did it. Oh, way too many people there. You guys want to split in? Do you guys want to split into 2 groups? Yeah. Why don't we? Here, let's. But. They'll fix it up for us later, right? Come on, join us here. And one more person from there. Come on, join us. No, her. But now the universe isn't having a study. Got one more set of papers? I have one. Oh, Peter. Okay.
study hypotheses, they might be blind to which study that patient is in. That's what we're doing. We're doing a sympathy study that has a chart in it, and my coordinators don't know which group the patient is in. So they have to abstract clinical outcomes in 3 days. They don't know which group A or B, and that helps to some extent reduce bias. Yeah, right, right.
So this is where our parallel
Well, they have a commercial department. But they also export it. There's a mention of a monitor.
Individually, and then you'll go through.
I think we'll just go through. Like two groups like minors. Okay, I think we're gonna try to start going through these papers as a big group, so that we get done on time. A couple of things that came up in my group that might be something to think about, and were some good questions, is one, what happens if you have a low kappa? So you train your abstractors and you do some inter-rater reliability. What happens if you have a low inter-rater reliability? Do you have to throw the whole study out? So what I would recommend is that the first 10% of charts that your abstractors are doing are the same. And then you know right away if the reliability is good. And if they're not getting it, then you need to retrain them and redo that entire set of charts before they pass, so to speak. So I wouldn't do like a random 10%. I would do that right away at the beginning so that you know if your abstractors are ready to go do independent charts. So go ahead and do that right at the beginning so that you know, do you need to retrain or are they ready to go? Does that make sense? Yes.
Where did you come up with 10%?
I think it's just kind of standard. Yeah, Martin.
Yeah, we were talking about that same concept. I call it a lot of times like a pilot. I think piloting anything is a really, really good idea before you launch into a big effort. Same philosophy holds for survey studies as well. I would never do a survey study without having piloted the survey tool with some, people that were going to be representative of who I was trying to use it with to kind of assess understanding and the like. So the same thing with this. I usually in my work I would say I piloted it with 10 or 20 charts and made sure that there was good fidelity to the protocol, the abstraction protocol, and there was no kind of discrepancies, and refined things. I think a reviewer is really happy to see I piloted it and we iteratively refined the research, the protocol, the abstraction protocol until, everybody was performing at a high level, and then we proceeded with kind of the full review.
Yeah, I think the other, when you get that low kappa, that low inter-rater reliability premium, it may be a problem with your data element, with the data collection element, and that's something that you should then look at. So the idea of piloting, the Mark said, is really important.
I have one more comment or two. So there's an abstraction tool, right? That's just what you're abstracting, and there's a code book. And I often want to look for a code book too, which is something that'll lay out if this and that, protocols. So it's if this and that all the way down. And so I'm usually looking for that as a keyword or something like there as well.
Yeah, I was going to say the same thing. You want a code book, manual procedures, some data dictionary, whatever you want to call it, so that your abstractors understand how things are defined and where to find things. So if you need a certain time, how are you defining that time? What time variable are they going to use? Is it the time of admission? Is it the time that they leave the ED? Is it the time they arrive to the ED? You have to be very specific in what each variable, where you actually get that data, so that they understand and it's not subjective. They're not just guessing, I'm going to just pull this time because it's right there and it seems like that's what they want. No, they need a very specific idea of what. And if they see conflicting things, which thing wins, right? So if you're reading a chart and you see conflicting answers to the variable, which one wins? All of that is going to be in your code book or manual procedures or whatever you want to call it, so that the abstractors understand and it's not, and they're also not coming to you every day oh, I didn't, there was this problem I had, and they already know the answers to all those questions. Okay, we're going to start going through the papers one by one, and so I'm going to start with Peter, and he's going to start with the pediatric paper.
Sure, thank you very much. So yeah, our group and also others may have done this paper, and I guess those groups who kind of reviewed the paper, what do you think? I mean, it was published, but how can it be, going through the checklist? What were the items kind of identified? One of the things in our group we talked about, I think is very important, is the blinding, right? The blinding, how do you blind retrospective chart review? It seems like it's very challenging, right? Especially to the hypothesis, because it was mentioned that certain IRB have to have all the study in staff who are involved in the study to be signed up, and then they will have to see the protocol, right? So how do you blind that, right? So there are ways to minimize sort of the bias per se. And one really good point that brought up is really, well, they may be understanding the hypothesis. You can blind them to the groups, right, for the abstractor per se. So that's one way of doing it. And there's other ways in terms of outcomes, how you can blind them. Some people, certain IRBs, I guess, are allowing in certain study group, study staff to be the blinding person. So actually, there are situations like that can happen. You can sort of discuss with your IRB and all that as well. But going over this paper, though, in terms of the items that were actually met in our checklist, being more structured and scientific, we'll just go to the next slide here. So the abstractor training definitely was not described. Case selection criteria, it was described, but then there was no exclusion criteria. The variable definition, we thought actually did a very good job in terms of explaining it and going into actually very good detail. There was no mention of attracting form. Performance monitoring, as mentioned, is so important to do it with trainees, med student, resident up front as well. Blinding hypothesis was not also mentioned. The inter-rater also were not mentioned and tested, were not mentioned at all. It was electronic medical record. fairly straightforward. Sampling method was also mentioned, but there was also, unfortunately, no missing data plan from an analysis perspective, how to deal with that, and IRB was mentioned. So that was our paper, and it was published in the Journal of Emergency Medicine.
Which other group, you guys had that paper? No, you didn't have, you guys, did you find anything else that you wanted to add to Peter's overview? Or you had it?
Like 0.5.
You gave it a 0.5?
No, we got to 0.5.
Oh, okay. Well, it looks like you got about, maybe not even 0.5.
Yeah, so there's a lot of things missing here that, are best practices that are not being done in this paper in particular. Okay, so we may sense a theme as we go on here. So my group and I think another group your group had the Hunger Games, and this was looking at fasting times for pediatric orthopedic injuries, and do you need to do a full fasting for sedation? So we had a lot of the same issues in our group, and please tell me if you have anything else. But they really had zero information about the abstractors. There was nothing about training. There was nothing about who even did it. There was nothing about how their performance was monitored, or even if they had any kind of inter-rater reliability measurement or anything like that, and whether or not they were blinded. So that was a big negative that we found. They did define their cases and their variables, which was nice, and they did say that all of this was from an electronic medical record, but they didn't mention. They didn't mention the abstraction forms and where they put the data, like in REDCap, or how they even had the abstractors put the data into the database. They did have a sampling plan, and they did say they just excluded any charts that had missing data, which is not the ideal way, but it is one way, at least it's an objective way, that you're going to approach your missing data. And then they did mention the IRB. So any other things on the Hunger Games?
They did have a significant percentage of missing data, over 30%.
Yeah, they had a lot of missing data.
To make you wonder what's going on here. Is it the records are so bad?
We thought the case selections were very good.
Okay. So they did have at least some description, but maybe they could have had a little better. Yeah.
Like an anesthesia law, ICD-10 search. We can see that.
Okay. I thought they said they pulled it by who got a sedation and then who had the orthopedic procedures. Oh, okay. Yeah. That's a good point. Right. So overall, again, more than half of the things are missing for this paper. Still published, which makes this is a problem that a lot of people are doing, missing some of these best practices. Again, this was published. Okay, let's move on to.
I'm sorry, I think it points out both of these papers, this one and the previous one, they used an electronic medical record, and it didn't really solve a lot of their problems. So it just maybe makes it a little easier to collect the data, but it doesn't deal with issues that are potentially biased in the study and the results.
Okay.
We're a little dizzy after this one, no pun intended. I'm a dad, so I gotta do dad jokes. But this was a study out of Korea that was looking at the predictive ability of a variety of lab tests and historical features and some medical history for patients presenting to ED with dizziness and where there's concern for stroke or other central lesion, and so they were looking to predict whether or not that was occurring, and I think we identified both problems with the abstraction side of things as well as some things beyond that. So it's important to kind of highlight, I think, both of those. So there's some good language here I think would be good to emphasize, but the abstractors were not really trained. They actually, there was a description that said they underwent like training, what was the terminology they used, that it was basically like the training that we all undergo every year for like HIPAA is essentially what their training was that they underwent. So they're emergency medicine specialists that I just thought this was great language. This basically tells me that they were absolutely not trained, because the description there, I don't know, we got it here. It was, we were repeatedly trained, we were repeatedly trained within a certain period on research ethics and data collection according to established standards. That to me sounds like probably not trained on anything specifically. The case selection criteria, we agreed that this was actually a decent strength of the study. It was very unusual, though, if you ever read this paper, that in their EDs, it sounds like it's very protocolized when a patient presents with dizziness. One group, if there's high suspicion for a peripheral lesion, and we're kind of a little bit caught up on this, that they would get a DWI, MRI, if there was high suspicion for a peripheral lesion. And then that was the group that they kind of studied. So it's just, so a priori, I guess, if you have very high suspicion for peripheral lesion, this may work for you, this test, but I'm not really sure, why that was the group being studied. Then there was a large group of people that were in the second kind of protocol, that if there was concern for central lesion, they would get CT, CTA, and then kind of other evaluation. But those were not the ones under study. So it was helpful to know that they picked the wrong group, and so they defined that. Variable definition, we had a couple issues with this, although there was description of what variables they pulled. One of the issues was the timing of the lab test was not specified. So they could have pulled from anywhere along the kind of inpatient continuum, and they did specify vital signs were from the ED, but the remainder of the history that was abstracted was not clarified from a time point perspective. So we see that as a particular weakness. Abstraction forms were certainly not mentioned. Performance, the word for monitoring, what did they use here? We were repeatedly trained. Sorry, it was. Yes. The medical records were first reviewed by an emergency medicine specialist, and subsequent chart review and data analysis were monitored by the corresponding author. So that also tells me that there was very little oversight. That they might as well have just said that. So yes, I agree that either not mentioned or probably not at all. There was no blinding. There was not any conduct of inter-rater reliability. They did describe kind of medical record identification method. It was using an EHR. Sampling method was was clear. So they did a good job with the case selection and the sampling method. Missing data, they actually later on described a complete case analysis. So they did do kind of also exclusion of any missing data, which again has limitations to that approach. But they did. I would say they did specify that, and Irb approval was obtained. So, but I think overall, the thing I mentioned, that's not captured here is that the selection of the cohort was very kind of an unusual selection of a group. So what actually, you're predicting at the end of the day would be if you have a patient who comes to you in the ED with dizziness and you have a high concern for a peripheral lesion, and you're planning to get an MRI and a consultation by a specialist, this model might apply for you. So it's, again, the utility of the prediction is very suspect.
And the thing you mentioned, Martin, about the one of the corresponding author having overview of the results sort of implies that there's a high risk of bias there, in that this person designed the study and has their whole life, or some slice of their life invested in seeing it come out the way they think it should come out. So.
Great. Thank you for all of that input. So I think we can see some common themes. So mostly these studies had some description of the IRB, some description of their variables and their statistical analysis. They had a few things that are important. And those are the more obvious things that, as you're writing a paper, that seem to be necessary. But they're often, all of these were missing details about the abstractors, the abstraction forms, and any inter-rater reliability assessment. These are very important steps that you need to take to reduce bias. And I wanted to mention one thing, because Peter was talking about the blinding, and that can be very difficult to do. A lot of chart reviews are like before and after analyses, so you could maybe blind your abstractors to the date of that, whatever the protocol change, or there are ways to do it that they're not blinded to completely, but there's some aspect of it that they're blinded to, and that at least, shows that you made an attempt to reduce bias, and that there's some parts of it that they, at least are blinded to. And kind of related to that, just because we have all of these 12 things doesn't mean you have to do all of them perfectly in order to have like an adequate study. But it's really about how do you address these areas of bias. So some of them are not going to be feasible. Like we just said, the blinding thing is really difficult sometimes. You don't have to do it in order to have a well-done study necessarily, but you at least need to address it in your methods and address it in your limitations. And if you do that, then at least the reviewers and the editors know that you have thought about these things. You tried to minimize it as best you could, and there were these reasons that it was not feasible, or these reasons that you were limited, even though you tried to, reduce the bias. So what we wanted to do, do you want to do this part?
Yeah, just go through this. How much seconds? Wrapping up. Okay, well, to wrap up, so Andrew asked me where his studies were. Unfortunately, they didn't make the cut for bad examples. 2 of these are his studies. Let's see if I get the 2 right. But they actually, and what he did was basically, he just wrote in, we did this study according to the protocol of Gilbert and Sullivan, the Gilbert and Lowenstein paper. Is that adequate? That's a tough one. I mean, I'm sort of counting on his honesty, and I know him, so of course he must be an honest guy. But it's nice to have a little more detail than that, although the fact that they even went to the trouble of noting that they did that, I think is a big deal. And it's a reasonable thing, especially if you're constrained by a word count issue. Although you might, the peer reviewers may say, well, we'd like a little more information. What was the inter-rater reliability or some particular issue with that. And you can scan this. This will send you to those examples, and also the papers that we talked about.
So yeah, it has the 3 best practice papers, the 3 kind of not perfect but better examples, and then an Excel form of, and then an Excel form of the list here that you want to really incorporate as you're designing your study, not at the end. You really need to take this list and say, okay, how am I going to tackle these things at the onset of study design, not later, because it will save you a lot of heartache, I promise. So,
I was going to just mention, you can take advantage of this, I don't know if you mentioned already, the supplement of almost every journal has an opportunity for a supplement, and this is, including your abstraction guide, your abstraction, like a PDF of your abstraction tool goes a very, very long way to the reviewer or editor in terms of the credibility of what you've done. So you could say, Kaji et al., file, and see supplement for all the details of our protocol.
And in fact, if you've gone through the trouble of doing it all, at least get acknowledged for it by doing that. So I think that's an excellent idea, Martin. I think we'll take any questions that people might have.
yeah. Anybody have questions?
So I'm wondering, as you do your chart reviews in the future with AI and skipping like half those steps because you don't have abstractors anymore, how you're going to think about that as far as what's a good paper and a bad paper.
I was wondering that too.
I actually have a program working on several papers that are all data abstractions of from the National Trauma Database, and I was thinking we haven't been the AI has been doing the abstracting, so I don't know. Do you have a suggestion for that?
The probably short answer to that one is just report what you know, report you've used ChatGPT or some type of LLM or AI-based model. Report what the model of it is, because older models are less reliable than newer models, and report what you did and what you didn't do. It's pretty good for data extraction. I'm less worried about that than other items, but I think the key is just reporting it.
Define variables and
We've done all that, but nobody's checked to see, I mean.
So,
Greater reliability, absolutely. You know, you should
Yeah.
do a 10% sample, you have the human code it out and see if that's.
Whoever it is, have that person also do 10%, just make sure the chat GPT or the AI is actually getting it right.
And I was going to say just planning ahead, because the biggest thing is you get into the charts, and then you start to figure out what you want, and then you want to make changes. And then so having those smaller samples to start, making modifications, iterations, before you go full-fledged. And then also the other point is not using the IRB as your methodologist. And you use them, understand that they're looking for human subjects protection for the most part, and they're not going to be looking up best practices for your methodology. So just getting approval from them is usually not the same as getting a peer review of your methodology. It's very, very different.
Any other questions?
I have one question, if I can kind of diverge. So one of the papers we picked was called Hunger Games. How many of you have seen Hunger Games, the movie? Raise your hand high so I can see. A few people haven't seen it. How many have read the book? Well, there's a couple, all right. I had a movie night with one of my granddaughters, she's 12. And I said, what do you want to see? And she said, Hunger Games. And I said, really? Sounds kind of inappropriate. Oh, Opie, I read the book. And then we watched the movie. I hadn't seen it before. I just heard about it. And at the end of the movie, I asked her, so which was better, the movie or the book? She said, oh, the movie was terrible. The book was great. On that note.
On that note, thank you everybody for all of your engagement. This was really great, and I appreciate your time.